Well, thank you to the pediatrics at Stanford. This is a really special occasion. And it's very special for me because this is actually my 50th year from graduating from Stanford. So here we go. I'm a setup person here basically today. The other people are going to talk about the science, and I'm just trying to frame this for what you're going to hear later today. And we've all seen this. I will move along. So I want to just, again, from the neonatal point of view, frame the patients that were described by Bill Northway so many years ago. Basically, these were kids with severe RDS on 100% oxygen who were apneic and moribund. And the BPD group were those that were then put on a ventilator for greater than 24 hours. And in this first report, there were early deaths within the first 2 weeks, less than 2 weeks, in 14 babies. Those were 31 weekers. There were late deaths at greater than a month. Those were 32 weekers. And some of the babies actually survived, and those were 34 weekers. All the survivors were on greater than 6 days of very high oxygen to have chronic lung disease. So you've just heard this description of the 4 stages of BPD, but the point, I think, for all of us is this initial definition of BPD really had 2 major components. It had a radiologic component and it had a pathologic component. And unfortunately, presently today, we're dealing with clinical descriptions, no radiology and no pathology. So this is really a unique and important situation. All right. Bill Northway chose the term BPD as a syndrome of chronic lung disease to emphasize the involvement of all tissues of the lung in the pathologic process. And clearly we have different babies today. They're much smaller, but still all parts of the lung are involved. And in fact, I like this definition rather than naming it something else. In that original paper, the possible mechanisms were described as healing of RDS, healing of RDS in infants who normally would not survive, caused by oxygen toxicity superimposed on the healing process, positive pressure, and poor bronchial drainage. And Dr. Northway's preferred causality was oxygen toxicity, which he went on to demonstrate in rodent models shortly after this paper. I want to just emphasize the last 2 sentences of this original paper. The apparent reversibility, even when retinograms of the chest show diffuse pulmonary involvement, is stressed. And then the final sentence, the continued genesis of potentially functional parenchymal tissue throughout most of the disease encourages a positive approach. And that is really, those are seminal observations about what we're actually dealing with today, where most of our babies actually survive and do remarkably well. So in 1967, these were larger, relatively mature infants. The initial disease was RDS, which it often isn't today. And the management was with high FiO2 and no PEEP, except Dr. Sunshine used a broken ventilator, which was very important because, as he pointed out, really the secret to ventilating babies was the invention of CPAP and then the integration of positive pressure into the ventilation. High mortality with a pathologic diagnosis. So we've gone over the last 50 years through a series of definitions which basically emphasize either oxygen use or the combination of oxygen and positive pressure at various times after the birth of the infant because our babies are getting smaller and more immature. And finally, with a challenge of oxygen to identify true oxygen need. So it turns out these definitions are relatively inadequate, and I'm going to talk about that. One of the interesting things about BPD is its incidence actually hasn't changed very much over these 50 years because we're taking care of smaller and smaller babies. This is NICHD data on the incidence of bronchopulmonary dysplasia up to about 2011, and basically the incidence is about 40%. This is a very interesting paper from the Vermont Oxford group just this year, looking at babies from 500 to 1,500 grams. And all of the 3-letter words of pediatrics, BPD, IVH, NEC, and so on and so forth, They're all getting better except for BPD. That's the only one that isn't decreasing up to this point of 2014. And my analysis of that is basically that we're taking care of smaller and smaller and sicker babies. But we're doing better with everything, including mortality, except the incidence of BPD. This is, again, these are setup slides for the rest of the presenters. Basically, BPD is a disease of severe prematurity in 2017. These are data of BPD versus gestational age, and it approaches 100% when you get down to 22 weeks gestation. Again, NICHD network data. Now, the thing that's really a problem for us as clinicians today isn't mild or moderate BPD, even in the tiniest babies. It's severe BPD. And severe BPD is completely driven by gestational age. And those are the babies that we need to work on in the future. The limitations of the definitions, first of all, have to face up to some facts that are often overlooked. In this population of extremely preterm infants, all preterm infants are abnormal, or they wouldn't have been born preterm. The lungs of these very low birth weight infants develop abnormally. All of them do. The lungs of very low birth weight infants are abnormal at 36 weeks and at term. And for all of these studies we do, there's no comparison population for the incidence of BPD, as we have no control group. Again, they're all abnormal, they're all preterm infants. The problem with the definition is that 36 weeks is an arbitrary time on a continuum of disease, and Dr. Ballard will probably address that. We define it by oxygen or positive pressure, not by pathophysiology, lab, or radiology. And the diagnosis occurs months after the opportunities to prevent or treat the disease. So it's not a very helpful diagnosis. The patients are unclassifiable with newer therapies, which are becoming very prevalent, such as high-flow nasal cannula, babies on no oxygen, and very low-flow cannula, where the babies are on 100% oxygen, which means severe BPD, but they probably don't need oxygen in the first place. Furthermore, the diagnosis poorly predicts long-term outcomes. And the way we're diagnosing BPD is really overlooking three categories of patients that are really important for how we think about therapies in the future. First of all, there's a lot of infants that die of RDS and BPD before 36 weeks, and they're not captured in the diagnosis. There are infants with severe BPD, which aren't emphasized or broken out in terms of severity, which is a problem. And then there are some infants that die with BPD after 36 weeks. And it seems to me these are the target populations for the innovative therapies you're going to hear later today. Who are these infants and how many of them are there? And that's a problem for us experimentally. This is a report from 2015 from the NICHD Neonatal Network on 22 to 28 week infants on causes of mortality and proportionality versus time on the x-axis. So I think we also have a problem with our data sets. The blue bars that are blocked out there are death from RDS. RDS is a limited disease. It's supposed to get better, and it does within a few days in most babies. But we have babies dying between 8 days and 90 days of RDS on death certificates. That's not a valid diagnosis at those ages. The other box is deaths from BPD. And our colleagues are coding out babies in the neonatal network that are dying of BPD at 15 days of age. You can't make the diagnosis until 36 weeks. And so those two boxes there are all actually misdiagnoses, and they're all candidates for therapy to prevent BPD. If you estimate the numbers based on the US population, there's about 1,800 babies that die between 12 hours and 28 days of respiratory deaths. I would argue those are potential therapeutic targets. And they're infants with severe BPD. That's about 18% of the population, less than 29 weeks. And that's about 7,200 babies. So we're looking at about 9,000 babies that we need to try new interventions on. And that's actually a really small number. spread across the whole U.S. So really this has to be collaborative research as we move forward. So these are an orphan population for new BPD therapies. The big picture, which you'll get more into today, is basically this for all of the lung development, that we have developmental exposures that degrade lung function in later life. And they can be preconceptional, they can be around the time of conception, they can be fetal exposures, and they can be early childhood exposures. And what we're dealing with our babies is a unique group of babies that are very tiny, very, very preterm, but they're exposed potentially to things from preconception until early childhood. And there's confounding lung abnormalities that put our babies at increased risk of severe BPD. One is fetal growth restriction, that's actually very potent. Pulmonary hypoplasia, which is virtually impossible to distinguish from early respiratory failure from other causes. Inflammation, pneumonia, and maternal smoking. These are data looking at weight percentiles for a group of babies between 24 and 31 weeks. And as you can see, both BPD and death are driven greatly by growth restriction. The less than 10% weight category babies are really extremely high risk of BPD. And there's a number of data sets that look like this. There are two inducers of early lung maturation that are of real clinical relevance. And induced lung maturation is really important because we either have less RDS or less severe RDS, and that makes the babies easier to manage. However, antenatal steroids, which are given to 80 to 90% of our women with very low birth weight infants, and antenatal infection, which occurs in 50 to 70%, are exposing the majority of our very preterm infants to inducers of lung maturation that also cause alveolar simplification. So part of the phenotype of BPD is driven by the things that improve the early outcomes of these babies in terms of lung maturation. It's very counterintuitive, but this is very clear in animal models. These are just examples of betamethasone and interamniotic inflammation endotoxin in preterm sheep, where the mesenchyme of the control lamb just melts away with these exposures with either betamethasone or endotoxin. And as I pointed out, at least 50% of our babies are exposed to both. So if one wants a new BPD diagnosis, it turns out it's pretty complicated because there's a whole bunch of things that one would like to consider, and of course the definition is used by different people for different reasons. So those clinical variables that contribute to BPD, which I just talked about. There's the early respiratory status of the babies that drives the diagnosis of BPD. There's research variables for those of us who are researchers. We're interested in genetic contributions, biomarkers, and molecular phenotypes. There's elements of the definition that include time. One can get a much better definition by area under the curves for exposures than at single points in time, but our epidemiologic colleagues aren't very happy with that concept. It's too difficult to do. There's severity of BPD at a single time, a scoring system, or continuously again. And then there's these respiratory deaths, which we actually don't capture presently. And the interested parties are the clinicians who just want to manage the patient, the epidemiologists who want something really simple and reproducible, the researchers who want to know about the pathophysiology, the drug developers who want a consistent definition that can predict an outcome, and the parents. And the predictability of the outcome depends on what you're interested in. Are you interested in respiratory, neurodevelopment, growth, performance at school age? So it becomes really complicated to decide how to make a definition that will make very many people happy at the same time. A couple comments on pathophysiology just to lead into the more complicated and better talks subsequently. As was pointed out, BPD is a collision of three programs. One is development, one's injury, and one's repair. And all those things in the yellow box are contributing to each component of this. And we don't understand any three of these pathways perfectly in the preterm infant. And probably much of the variability in how these kids present is the variability in how the kids are presenting with their lung development program, how much injury is occurring, and how effective their repair may be. I'll skip that slide. And there'll be a couple talks on follow-up, and I think this is really an important area. It turns out that most preterm infants, as I mentioned, actually do remarkably well. The variable results that we see in the literature suggest airway disease, increased asthma, decreased exercise tolerance, but I think there's a real perspective problem on the interpretation, what's normal enough. And again, without challenge, many of these kids do very well. And then finally, what's the trajectory of that abnormality into adulthood? We now know that the lung continues to grow and remodel, which is really, really fortunate, or we would have a big problem with these tiny babies. And we concentrate on the worst cases rather than the general population of these babies. I like this slide because it's population-based for infants less than 26 weeks gestation in all of the UK, and this assessment was for babies born in 1995. When they're 11 years of age, the babies with BPD do have a lower average FEV1, a measurement of lung function, than a term comparison population, and it's a bit lower than the no BPD lungs. But the no BPD lungs aren't a lot better than the BPD lungs, and by 11 years, most of the BPD patients on an epidemiologic basis are actually in a normal range. So again, this is hopeful, and we'll hear more about that later in the conference. So in concluding, I'm just going to read to you these last two sentences of the original paper, because I think this is what we have to focus on. The apparent reversibility, even when rentgenograms of the chest show diffuse pulmonary involvement, is stressed by Bill Northway, and the continued genesis of potentially functional parenchymal tissue throughout most of the disease encourages a positive approach. So we have to be really positive about new therapies. Thanks very much.